Yeah. Good morning, everybody. Thank you, Jaivishan sir, and the organizing committee for this opportunity. So today I'll take a short, 10-minute presentation on recent advances in male fertility. So for a long time, recent advances in male fertility was how we can retrieve sperms in those we don't, those who have azoospermia, and how obesity, lifestyle changes, and smoking, things like that affect male fertility, right? So now, just as a brief introduction, we know that infertility is a common medical problem, and now male fertility contributes to about 50% of the cases. Earlier it was only about 30 to 40, but now it's about 50%. And 30% of those cases are idiopathic, we can't find out the reason why those men cannot, help the women conceive. So over the last 40 years, developments in male fertility diagnostics, including genomics and molecular testing, have helped us get the diagnosis for these 30% of the cases, right? So previously what was considered unexplained infertility is now having a name to it. These are the guidelines that we're using right now to diagnose if a man has normal semen parameters or not. As you can see, the 5th centile is what we are considering as normal. So the semen volume should be 1.4 ml, the concentration 16 million per ml. And in an ejaculate, he should have 39 million totally, and so on and so forth. So now, coming to the recent advances or any changes in how we manage male fertility, the main points are DNA fragmentation index or sperm DNA fragmentation testing. The recent guidelines, the latest WHO guidelines have no clear guidelines as to who should be tested and when we should be doing the testing, and what medicines to give suppose he has a high DNA fragmentation. So in our clinical practice, what we can do is consider these situations as possible indications, like those who have varicocele, or if a couple is having recurrent implantation failure, after multiple attempts of embryo transfer and things like that, or if they're having recurrent pregnancy loss after conceiving, and if he's a heavy smoker, right? And then there's been a lot of work done at developing systems so that men can check their semen at home, because some people are very worried or very uncomfortable giving the sample in a lab or a hospital atmosphere. For these people, we can use these instruments after their validity checking. So we have a lot of instruments: sperm check, the YO system, the track system, and the microsperm test. All of these either use smartphone cameras or some software to detect whether the sample is normal. As in, they take a video or photo of the sample at home and they can give you a report saying whether it is normal or abnormal. But the problem with these things are that since there is no trained professional looking at it, how much can we rely on these test results, and how do we plan the treatment of these patients are still to be decided. And as in everything, artificial intelligence is taking over. So in a slow way, it is coming into andrology also. So in a multi-institutional study done by Ori et al., a machine learning model successfully predicted subsequent upgrades in sperm parameters in 87% of men following varicocele repair. So, and a smartphone application is being developed that can be used at home to check your motility, sperm motility and things like that. And also in the morphological assessment, models have been developed based on unstained images to improve the XC technique by classifying images in real time. So all these things are aimed at improving sperm, selecting the sperm for XC, giving better results, getting a good embryo in the end. And whole genome testing, this practically has helped understanding several male infertility states. This is mostly into diagnostics. What we do after diagnosing is still unclear. What therapy we have is still mostly what we used to do all these years only. So several genes have been identified in the context of non-obstructive azoospermia, and if these genes are identified, the main thing is we can counsel the patient whether we'll retrieve the sperms while doing TESI or micro-TESI, things like that. And also the same thing with epigenetic markers. Many non-obstructive patients, non-obstructive azoospermia patients have found to have a lot of epigenetic markers which are unique this condition, such as EXX1. It was identified in 95% of men who had spermatogenesis in the testicular tissue. Also, another study demonstrated that these 396, 395, and 378 microRNAs, they were expressed in the different stages of cell development in the sperm, like spermatogonia, Pachytene spermatocytes, and round spermatids between non-obstructive azoospermia patients and with obstructive azoospermia. Also, it is suggested that epigenetic markers may resolve much of the current uncertainty that surrounds the prediction of the presence or absence of spermatogenesis in azoospermic men. So how we can use this in our clinical practice is only to counsel them to say that there is a certain chance that you may get sperms or you may not get sperms. Seminal proteomics is because semen has a lot of protein substances in it. We can identify different seminal protein expression profiles between patients who are fertile and infertile and see that whether these can be used as a diagnostic marker to predict whether this couple can conceive in the near future, right? So those who have a varicocele also have an altered seminal plasma proteomic profile, and 64 and 31 proteins were expressed in bilateral and unilateral varicocele patients. Seminal protein RNAs could predict the presence of spermatozoa in patients with non-obstructive azoospermia in certain instances. Now we come to radiomics. This is basically the ultrasound or radiographic findings of the testis, and using that to predict whether this patient will give us sperms when we try to treat them with ART. So a pilot study compared scrotal ultrasonography findings and testicular function represented by semen parameters and reproductive hormones. The results showed that the ultrasound-related textural features were correlated and predicted sperm concentrations and total counts, total progressive motility, morphology, and gonadotropins, but did not correlate with the serum total testosterone levels. So these are all the recent advances which I could find that we have not sort of started using over here, but mainly all that I've talked about is to counsel the patients, right? Does it really change our clinical practice, or is it really going to help the couple? Is yet to be found out. Thank you very much.